Hello everyone. In the series of Docplexus KOL interviews, today we have with us Dr. Prakash Trivedi, who is a renowned gynaecological endoscopist. Dr. Prakash Trivedi is one of those gynaecological endoscopists who has performed more than 36,000 gynaecological endoscopic surgeries. He is the immediate past president of FOGSI and is the Asian brand ambassador of FIGO. Dr. Prakash Trivedi has received many awards and accolades and is today here with us to share his valuable experience with us. So the first question that we would like to ask Dr. Trivedi is, can you highlight some practice-changing breakthroughs in total laparoscopic hysterectomy?
There are a lot of, India is a country wherein removal of uterus traditionally, we have geniuses who do vaginally, that is remove from below, and people who are not trained to remove from below, they have an habit to do an open surgery. Since 1991, from when we started pioneering and doing removal of uterus through the laparoscope, in last 25 years, there is a sea change wherein, unlike even America, unlike even Europe, probably India has the largest number of laparoscopic removal of uterus, laparoscopic removal of fibroid than any country in the world. The reason being, A, that there are plenty of indications and plenty of patients who need either removal of fibroid or removal of uterus, and still bigger being the past president of FOGSI, which is around 32,000 gynecologists, which is the biggest in the world. So we do have a fair amount of expert endoscopists in every corner of India who do removal of the uterus, though laparoscopically, with different techniques. And the techniques have now evolved and has matured, wherein we have a world standard, which we showed in the first week of June, wherein 63 live surgeries were relayed in Bombay with all the world's experts with different technique, and they were glued up with something which is not possible, with something which we cannot imagine.
Great, sir. So then can you please highlight on the criteria to select patients for total laparoscopic hysterectomy?
I think that's a very important question, because when there's a new technology, there's a tendency that people start overusing that for a particular place. Minimal access by definition is that either you remove vaginally or you remove through buttonholes. So that means you are avoiding an open surgery. So in all those situations wherein you can remove the uterus from below, and Indians are better trained to remove from below compared to anybody abroad, whether America or Europe, because we have a large amount of training in vaginal surgery. Once you take the vaginal part out, then you have a huge number of patients who need an open surgery because of fibroids, because of large masses, because of large uterus, because of adnexal mass, which can be ovarian cyst, early cancer, and many other reasons. So basically the technology has moved to such an extent, because ours is a referral center. So from 1997 we remember that 98% of the hysterectomies or procedures of removal of fibroid or cyst were done through laparoscope or vaginally, which means only 2% cases were done by open, because ours is a referral center and we have been groomed and trained. That is not necessarily with all 32,000 gynecologists. Many of them are comfortable with abdominal because they are not trained in laparoscopy. So they still prefer to do abdominal surgery, which is perfectly fine, because everybody cannot be an expert in all surgeries. As far as laparoscopic indications are concerned, that is very important. Once it is sure that you have to remove the uterus for excessive bleeding, the size of the uterus is big, which means you would not prefer it to remove vaginally. There are multiple fibroids or there are large fibroid. We've been fortunate to remove even 4 to 4 kg size uterus through the laparoscope. Then you have large ovarian masses, you have endometriosis, you have many other tubal disease which may need removal of uterus. all this is a large group of indication wherein laparoscopic hysterectomy can be done efficiently and nicely with different techniques. Currently it is best placed, in spite of some controversy which we will be discussing, but I think so we are in an era wherein we are celebrating the advantages of minimal access surgery, wherein women gets up in 2 days, and third day, to be precise, on Friday I operated my wife for a large fibroid, which was the whole size was approximately equivalent to 4 to 5 months of pregnancy, and on Sunday she is an embryologist. She resumed her work on Monday and she is back to. So you can understand that if this is the situation, the plenty of patients in India need, because many of them have low hemoglobin. The women in India is very important because the house comes to standstill when the women in the house is not at work. So once you do through minimal access surgery, and when the patient recovers within 2 days, she's taking mild rest for 7 days, in 10 days she's back to normal work. I think it's the biggest boon for any women in the world, more especially the women in India.
Great achievements then, sir. So we were talking about the recent advanced techniques, then we would like to know the major benefits that are associated in respect to the recovery and post-surgical complications.
See, what happens is with an open surgery, there was a standard pattern that you will have maybe 1 month, 2 months, 6 weeks, or even sometimes 3 month rest with good food. And what used to happen is invariably the patient used to put on weight. So that is a major issue which we had. And because the patient is more sleeping and resting, there were issues related to the comorbidity because of so much of resting or the large incision. Now with buttonholes, which are half centimeter or maximum 1 centimeter, the entire thing goes away because patient takes bath on the next day, patient is walking on the next day, patient is back to normal work within 10 days, except that any method of removal of uterus prevents sexual relationship for 2 months, which is with any technique. But what happens with a good expert laparoscopic surgeon, the patient hardly feels that they have actually got a surgery done, so they can really focus on to issues which were other than that. And more important is, once the pathology is removed, which may be fibroid, once the bleeding part is removed, they are relieved, and we on the contrary suggest them not to take much rest, no restriction in lifting, no restriction in bath, no restriction in resuming office or normal work, which is a big boon for the women.
So, talking about the paper, you have recently published a paper on laparoscopic morcellation of fibroid and uterus in a bag, and there's FDA issued a warning recently, and there is a lot of debate going on in Western countries. So, what would be your comment on that?
I think it's very important because with the amount of skill which India has, amount of science which India has, and many other countries has, I think so. Vaginal surgery, Vienna is great. Sometimes it's shocking that if there is rain and there is thunderstorm and lightning, one lady is affected or one man is affected, the whole city will not go out in rain. That is America. We had one case reported of leiomyosarcoma on an anesthetist who was operated, and they blew it out of proportion, and they almost made morcellation the culprit, and they have withdrawn morcellation. So in today's time, if you are in America, if you have 3-4 fibroids, or if you have a uterus which is large, which is to be removed, the only method of removing is you can do separation with laparoscope, but the removal has to be done again by widening the, so it is as good as doing an open surgery. Now there is this undiagnosed leiomyosarcoma, as we have studied. I had 9,600 laparoscopic myomectomy, no case of leiomyosarcoma. In India, 10 colleagues of mine, of which 5 are of my level, we have lakh plus myomectomies. Total number of cases reported are hardly few. Then we extended that if you remove the uterus, uterus also can have cancer. So we started understanding that this issue was more hyped than actual. So what happened in America, they moved the lawyers, they moved the Wall Street, the Washington, and they withdrew the morcellator. As world, I always feel that when world is wondering about problems and what can we find solution. So somewhere last year, we had this huge conference now. Last year we had a big conference. So I started working on a design wherein when you separated the entire specimen, we design a bag so that the separated fibroid, separated the uterus. After that, when you want to remove, the bag is introduced inside the abdominal cavity. The bag is open. You put all the specimen inside. Bag has a side ear or a nozzle which comes in the main port. The bag comes out from the side. So the whole specimen is inside the bag. And when you connect the gas, that is the pneumoperitoneum, the whole bag expands. So the specimen is within the bag, and from the same hole you go ahead and you morcellate. From 14th May 2015, back to back, every case of removal fibroid or uterus we have done with in-bag morcellation. So it doesn't spill one drop, one cell. So the issue about morcellation, spreading, it doesn't hold true. There's a big mistake which is done in America. Say for example, when you're removing fibroid, so you're dissecting it out from the uterus, whether you're doing it laparoscopically or in open surgery. So when you're dissecting, you're playing with the specimen for 1 hour, 1.5 hours. Nothing can tell that cancer cells should not spread at that time. So it's only when morcellation comes, the cancer cells will spread, which is, according to me, ridiculous. Because morcellation involves spinning. So that is why they started thinking that that is what can spread. 2003, I had introduced a bipolar morcellator. So there's no spinning. So it just cuts straight. So what I thought is, rather than, getting, all our women of India getting converted to open surgery, we found this in-bag as a solution, and we find that we are doing it nicely. The Indian journal is published. All the foreign surgeons, American, from France, from everybody were present first week of June in Bombay. They saw the bag technique. They saw many other things. I am pretty sure that we have so many patients coming from abroad, because you cannot do minimal access surgery, because after the buttonholes, you have to widen the incision, which may be umbilicus or something. It deprives the patient of the primary benefit, because if you have a 12 centimeter fibroid, how much you are going to widen? So basically, it deprives, because American medical profession works not taking only women into consideration. Under the name of women's safety, the lawyers and the politician pressurize them to condemn a technique which was popularized without even understanding that what they are withdrawing is probably not in the larger interest of the patient. Here we have almost now much more than 100, and we are having a systematic follow-up 6 months later with sonography, with MRI. Probably we are the largest series in the world, and that is what we are going to publish in the American journal only. That this was done for a period of 1.5 to 2 years in, say, 400 patients or whatever the number is, irrespective of size, and there was no case of spill or there was no case of problem. So I personally foresee that they will copy the Indian intelligence of solving problem, rather than getting scared legally and making lawyers and politicians decide what we should practice, because we don't teach lawyers how to do law. I don't understand why politicians and lawyers and the media suggest what doctors should practice. It really doesn't make any meaning, and I'm sure in another 2 years' time everybody will be following this total healthcare technique, because everybody found that it is, if not this, they will modify a little bit, but that should be probably a good breakthrough. We also have to understand that laparoscopic surgery is done for cancer. Yes. So you're dissecting cancer cells while doing laparoscopic surgery. So this imaginary fear about undiagnosed leiomyosarcoma, which actually they quoted initially 1 in 350, then they went to 1 in 1500. Now the core group says that it may be 1 in 8000, which means we'll subject more than 8,000 people to do an open surgery for one imaginary leiomyosarcoma, which can take place in a patient after removing the uterus, even by open surgery. So even if you do by open surgery, there can be 50% chance of residual leiomyosarcoma, which increases in laparoscopy by 10%, and in back it goes to 0%. Because only if there is an existing disease, then it can spread. So I think so probably India is more well placed, and America has realized that this is the situation. The last conference, this was it was an ideal combination of two of the biggest democracy and the best surgeons in the world operating together, and everybody seeing each other's technique. We appreciated so much of their technique. They were shocked watching the actual skill of Indian surgeons. And fortunately, I had all the best Indian surgeons, all the world's best, not only laparoscopic surgeons, vaginal urogynec surgeons, robotic surgeons, 12 operation theatre running, relayed in one of the 3 parallel auditorium with 7 screen, probably which has never happened in last 50 years, and which is not going to happen because showing 63 surgeries in 2 days has never taken place in the world. And even the AGL board, they themselves are telling that this history is difficult to break. But we are not done to break any history. We had focused on each procedure so that it doesn't look like we are overdoing. So each procedures were explained nicely, and 1400 people witnessed it.
Great. Thank you so much for elaborating the technique so precisely, and definitely our gynecologist will be very happy to see it. We also will be glad if we get an opportunity to demonstrate this technique as you did in the conference, so that they can have a look through it. Thank you so much.
Sure.
So one thing that I would like to ask lastly is, there are different methods of training young laparoscopic surgeons that are budding surgeons. So what do you think is the best training method for the gynec endoscopist recently?
That is very good, because what happens is, people do attend a short course of 4 days, 7 days, and on the 10th day they start operating. Fortunately, I was a president of FOGSI and also the president of Endoscopy Association, just finished the tenure. The current president, Alka Kriplani, she is also an endoscopist. So FOGSI has a structured training program. My center is fortunate that Maharashtra University has recognized 1 year training in minimal access postdoctoral. So basically, people can get exposure to training in India itself, which may be initially of 1 or 2 weeks, which is exposure. Then we have a 6 months training by the college, which we have in FOGSI. Then we have this 1 year training course with the university recognized. So I think so they can take advantage of these courses, because in this they can actually be in the OT, sometimes they can scrub, they can wash up. The education here is far superior. The same thing when you go abroad and do, you have to just stand and watch. You can't touch the patient. Okay. And for that training, you have to pay a bomb as a fee. So training abroad also is very useful and important, but there's so much of good training going on in India that first finish in India, so that when you go out, suppose if you are thinking that you would need 1 year, you will finish that part in 15 days. So training is essential. Training should be done with excellent teachers and not necessarily one. Unfortunately, it is not in curriculum of the medical college, which will take a little time and pick up. Hospitals like AIIMS and all do have. I am at Rajawadi Hospital and my own center. We do have a regular training which is going. Normal MD, MS in gynecology, the curriculum doesn't have, because the hospitals we are talking about teaching, they don't have the equipment. But it will be not too far, wherein there are plenty of centers which are going to have the postdoctoral training, which like our center has, and many more centers will have. And such trained people, I have 5 trained experts in Pune who have worked with me, and so many people all over India. So they all are doing excellent work in minimal access surgery, and fortunately some of them are even doing better than me. So basically we have to understand that if you are a genius in surgery, you have to create more geniuses in India, which is not difficult.
Great, we really like your motto, sir, and definitely there is nothing better than practical knowledge. So we really would like to thank you for sharing your valuable thoughts, sharing your new innovation, and having your time spent with us. Thank you so much.
It's my pleasure, and it was great to share my opinion. Thank you very much.
Thank you. These interviews and videos are brought exclusively for the members of Docplexus community. To stay updated about such upcoming events, we would request you to subscribe to our YouTube channel, like our Facebook page, and follow us on Twitter. Happy Docplexing!